Welcome to the Explainer. Today, we're going to build a clinical framework for understanding inflammatory rheumatic diseases. We're going to start with the absolute core principles of inflammation and then see how they play out in a classic case that you will definitely see in practice.
Okay, so here's our game plan for today. We'll start with the big picture, what makes a disease rheumatic, then we'll get into a really important distinction, acute versus chronic inflammation. From there, we'll meet the key molecular players, the tools the body uses, and finally, we'll see how this all comes together in a real-world case of gout.
So when you think about conditions as different as, say, gout and lupus, what's the one thing that ties them all together? Well, it's right there in the name, inflammation. That's the common thread. It is the central process, the engine really, that drives all the joint and organ damage that you're going to be managing in your patients.
Now, one of the most powerful ways to start thinking about these diseases isn't just by what part of the body they hit, but by their kinetics, basically how they start and how they keep going. This whole idea of an acute one-and-done process versus a chronic self-perpetuating cycle is absolutely fundamental for diagnosis and for treatment.
So let's break this down. On the left, you've got your acute diseases. Think of these like a sprint. There's a really clear starting gun, a urate crystal, a bacteria, and the whole point of the race is to get rid of that stimulus, and then it's over. But on the right, chronic diseases, they're more like a marathon with no finish line. The thing that started it all might have happened years ago, or we might not even know what it was. The process just becomes this vicious, self-perpetuating cycle where the immune system starts attacking the body's own tissues, what we call self-antigens.
And this slide right here visualizes those ideas perfectly. Look at the top diagram. That's acute inflammation. See how the response gets activated, but it also triggers an inhibitory loop? That's the built-in off switch. Now look at the bottom diagram for chronic disease. That off switch is just completely overwhelmed by this nasty auto-amplifying cycle. Here, the tissue damage and the cell death, they don't stop the process. They actually create more of those self-antigens, which just adds more fuel to the fire. It's like throwing gasoline on it.
So what are the actual tools the body is using to cook up all this inflammation? Let's meet the key players, the molecules and cells that are part of the body's inflammatory toolkit. You're going to see these come up again and again in rheumatology.
Okay, this is step one. How do you get your inflammatory cells, your neutrophils and your monocytes, out of the highway of the bloodstream and into the tissue where the problem is? Well, pro-inflammatory cytokines like TNF-alpha and IL-1 beta act like signals that tell the local blood vessel walls, the endothelium, to basically put out a sticky landing strip of adhesion molecules. These grab the cells as they fly by and pull them into the tissue.
So if endothelial activation is the landing strip, then you can think of cytokines as the battle plans. They're the signaling proteins that coordinate the entire immune response. And the specific mix of cytokines that gets released, which often corresponds to different types of T helper cells like Th1 or Th17, determines what kind of cellular army shows up and what kind of fight they're going to have. This is why you get such different pathologies.
Next up is the complement pathway. This thing is a huge amplifier of inflammation. When this cascade of proteins gets switched on, it does two main things. First, it acts as a powerful chemical beacon, screaming, "Hey, immune cells, get over here." And second, it can form a weapon called the membrane attack complex, which literally punches holes in target cells and destroys them.
This slide illustrates a point that is so crucial for understanding diseases like vasculitis. It's not just about having antigens and antibodies around. It is all about the ratio. It's kind of like a Goldilocks situation. If you have way too much antibody or way too much antigen, the immune complexes that form are cleared out pretty easily. But in that middle zone, with just a slight excess of antigen, you form these perfect, medium-sized complexes. They're too big to stay dissolved, but too small to be cleared out efficiently, so they get stuck in blood vessel walls, they activate complement, and boom, you get vasculitis.
Okay, so we've met the players. Let's put all these pieces together. We're going to take everything we just talked about, the initiators, the cytokines, the cell recruitment, and see how it works in our case study, a patient having a classic screaming hot gout flare.
So let's get clinical. Picture your patient. They wake up at 2 a.m. with this excruciating 10 out of 10 pain in their big toe. The joint is bright red, it's hot, it's swollen, and they can't even stand the weight of a bed sheet on it. That's classic podagra. So what exactly is going on at the cellular level to cause such an intense reaction?
This diagram right here, this is the cascade you need to visualize in your head. Let's follow it from the top. It all kicks off with that initiator, the sharp, needle-like monosodium urate crystal. The flare officially begins the moment a local macrophage in the joint, our first responder on the scene, finds one of these crystals and eats it.
Let's just walk through this play by play. Step 1, the macrophage swallows that crystal, and that triggers it to sound the alarm, releasing a flood of pro-inflammatory signals like IL-1, TNF, and IL-8. Step 2, at the same time, the surface of the crystals themselves directly switches on the complement pathway. Step 3, all of these signals, the cytokines and the complement factors, create this incredibly powerful chemical trail that screams for neutrophils to come to the joint. And step 4, a massive army of neutrophils arrives and just unleashes its entire arsenal, causing that intense, fiery inflammation of a gout attack.
Now here's a really key feature of a gout attack, and really a hallmark of acute inflammation. It stops. It resolves on its own, even if you don't treat it. The inflammatory response actually has the seeds of its own resolution built right into it. It's designed to shut itself down.
So how does it stop? Well, it's not just one thing. It's this beautifully coordinated effort. The body's clearing out the crystals. The heat and fluid from the inflammation itself actually helps dissolve more crystals. And proteins in the joint fluid start coating the remaining ones, making them less inflammatory. Then the macrophages start secreting anti-inflammatory signals. And here's what's really cool. When those macrophages start cleaning up and eating the dead neutrophils, it literally flips a switch inside them, turning them from pro-inflammatory to anti-inflammatory cells.
So the big takeaway here is that gout is the perfect textbook example of an acute inflammatory disease. You have a clear trigger, the urate crystal. This leads to a very focused response, driven by the innate immune system, specifically macrophages and neutrophils, and those humoral factors like complement. But, and this is the key part, it's a response that is ultimately designed to be self-resolved.
And that really leaves us with a question for the future. As you go forward in your training, think about these pathways we just laid out. Interrupting these cycles, blocking a cytokine like IL-1 for gout or TNF for rheumatoid arthritis, that is the entire foundation of modern rheumatology. Understanding these mechanisms isn't just an academic exercise. It is the absolute key to understanding the drugs you use today and developing the next generation of therapy.